Good afternoon. Slide. Good afternoon. Welcome to this session organized on behalf of Global iGenetic Consortium. And we had our first international meeting, and thanks to Dr. Shailaja, who's a product of NEI and SROF, who was a major contributor for that, along with our executive body. So we had this in 19th and 20th November. We wish we should do that in the year, and I'm sure Dr. Shailaja will mention about her session on rare eye disease on April 7th. मूव नहीं हो रहा है. Okay. So our objectives of the Global Eye Genetic Consortium is to share genetic information to isolate common genetic variants associated with genetic eye diseases, establish cost-effective genetic analysis and accurate diagnosis for grouping of genetic eye diseases, and develop research-oriented database to collect and catalog genetic eye diseases at a global scale, and support and foster global collaboration for the advancement of genetic eye research, collaborate with other international or regional organizations with similar goals, organize regional congresses and other educational and scientific activities to promote goals of the consortium. In 2014, during the World Ophthalmology Congress in Tokyo, a memorandum of understanding was signed by former directors Paul Sieving of NEI and Yozo Miyake, one of the authority on ERG, on the inherited retinal degeneration, from the National Institute of Sense Organ, to cooperatively work to study genetic eye disease in Asia, and it was called as Asian Eye Genetic Consortium. And later we had myself and Dr. Paul Bird. We were I worked as a Secretary General and Paul Bird as a Vice President, and later Calvin Pang as the Scientific Chair, and we also have Robert Hufnagel from NEI, now who is in Hawaii as a second Vice President. And we have a networking database and publication. We have already made 4 books. And this is actually the main work is being done by Dr. Takeshi using the GEGC database. GEGC stands for Japanese Eye Genetic Consortium. He is ready to give to us. Somehow we are not able to take. I hope to myself and Dr. Shailaja will take it as a homework and have every continent, including India, to do it. And thanks to Dr. Arun Singh, we have made 4 volumes of this book on the advanced research. This is our Takeshi is our president. Dr. Gyan Prakash is our patron. Paul Bird is Vice President along with me. And this is an old slide, which was in, now Dr. Shailaja is our Secretary. So this was the Maharashtra Ophthalmic, which we did the conference, and that was done well. So and we also, as a part of this, because I'm working with Dr. John Prakash and Calvin Pang and Professor Kumar Manikwal, who's there. Professor Kumar Manikwal worked in NEI in the 2000, and we have started in my father's name, late Dr. N.S. Sundaram Genetic Eye Clinic. The idea is to collect phenotype and genotype. That's my late father. And this is what we have created a team. We have also have research in ophthalmology. And so the main idea is we also have now a grant from BIRAC, which is mainly for clinical registry, but under Government of India we applied. Unfortunately, it was rejected. Now we are reapplying to ICMR. So the special thanks to the AIOC204. We are working on genetic eye clinic, but we don't have a trained person like Dr. Shailaja, but Shailaja to guide. I also take this opportunity to invite all of you to the International Council of Ophthalmology, me as an office bearer from India. Thank you. So now I request Dr. Shailaja to take over and go with the proceedings.
Thank you, Professor Natarajan, for introducing everyone to GEGC. Without much delay, I think we'll start the scientific session. So we have around 5 talks. First, that would be mine, and then as and when the speakers are there, we'll introduce them. Can you help me to connect the laptop? They asked me in the laptop.
HDMI है ना?
कनेक्टर ला
This is an Apple.
सरफेस माइक्रोसॉफ्ट सरफेस
शो लगा दीजिए.
भैया ये है ही नहीं इसका नहीं I'll skip the introduction and go to the talk. So I would be speaking on the genetic aspects of anterior segment and whole globe abnormalities.
Counseling or preconceptional counseling. I think these, if you have the test results, you can counsel the parents and prevent recurrence of the disease. So these are some of the pictures from our institute. All types of disorders we see in our clinic. So what are the steps to diagnosis? When you get a patient with congenital or developmental glaucoma, the first step is to establish a robust phenotype. And then I think it's very important that you do pedigree charting. So we have geneticist with us, and she charts this pedigree chart, and it helps us to understand human disease inheritance pattern, with whether it is autosomal dominant or autosomal recessive, incomplete penetrance, or variable expressibility. So I think it is very, very important, and it identifies individuals at the risk of developing a disorder. So which test to perform? Again, I think a geneticist can help us to understand which test to perform, and it can be a single gene panel which includes common gene associated with a particular phenotype. Like if you are testing for aniridia, you can just ask for PAC6, but in India it is not commonly done, and so you can have multiple gene tested in one panel. That I'm going to discuss. And it is essential, however, to understand that not all pathogenic variants are detectable by conventional sequencing, because as I said, gene deletion and duplications are possible, and which may not be detected by simple genome testing or exome testing. So you have to sometimes do PCR, etc. So single gene panel, multiple gene panel can be performed. I'll be just talking about a few cases. This particular patient, 20-year female, who presented to us with corneal scarring, and she also, gives similar history of similar problems in sister and mother. Although there was no birth and developmental history, so you can see corneal scarring with loss of limbal palisades. So basically, this is a case of aniridia, and superiorly subluxated lens. Gonioscopy showed PAS, extensive PAS, and stumps of rudimentary iris in the left eye. There was involvement of fovea, as well as the disc was abnormal. So in the pedigree charting, we can see that the members affected were sister, mother, and half brother. So the lady was married twice. So we advised clinical exome sequencing, and it came out to be a variant of uncertain significance, VUS. So we didn't find any pathological variant here, but we were not convinced, because she had this familial history of sister being involved and mother being involved and half brother being involved. So we tested her sister as well as uninvolved maternal uncle. So the sister again was positive for this particular variant, whereas the uninvolved maternal uncle was tested negative. So that kind of confirmed that there is this is the pathological variant which was reported as VUS by the lab. However, the search in ClinVR suggested that mutation is pathogenic, and this particular mutation was described in literature in 6 such reports. So I think that kind of confirmed that this was a pathogenic variant. So it is not necessary that you get a positive result always, but phenotype will suggest that something is abnormal. This particular patient, just 2 minutes. So this particular patient, sometimes you do not require genetic testing at all. So this particular patient, the clinical features were quite suggestive of mucopolysaccharidosis. So the patient presented with hazy cornea, which was diagnosed at either shed or congenital glaucoma. He had short neck, small chest, kyphoscoliosis, and telecanthus long philtrum. As you can see, the clinical features were quite suggestive and short stature for age. No family history, so we thought it is one of the mucopolysaccharidosis. So genetic testing was not essential. We just sent the patient for measurement of urinary gags, which are abnormal, and enzyme therapy can help. Again, this is Sturge-Weber syndrome with CVI. So you have to have a very robust phenotype evaluation and do a systemic evaluation as well. This last case, Peters anomaly, again, the child has very severe glaucoma with very poor vision, and TRAP plus TRAP was done in AIMS, and she had tested positive for rubella, so as the mother, and this was a clinical picture. Optical iridectomy was performed for her at AIMS, and we had been doing her EUA. After that, eggshell, there was an enlargement of the eggshell length, as well as IOP was also not controlled at the right eye. UBM showed typical pictures of Peters anomaly in both eyes with corneolenticular touch also. So the prognosis was very poor, and this was the clinical findings of IOP. Again, this child was, was tested positive as PAX6 mutations. So I think that gave us the prognosis. So that is the prognostication that this child is not going to do very well, although the parents were very hopeful. So I think you can counsel the patient, and if they're planning for second child, then I think they can just get it tested prenatally and preconceptionally. So this is our data. Now we have been doing the genetic analysis of all children who present to us. The genetic testing has also become cheaper now, and most of our children, out of 29 children, 10 were VUS, 9 were CYP1V1, and some of them were TEC, LTBP2, and POXY1 and PITEX2 when there were evidence of Exenfield, Rieger, and Peters. So I think we do get positive results in genetic testing, and that gives us hope, and we are quite sure of the diagnosis. So I think it's very important to do a complete evaluation, but phenotypic, I think, evaluation is must, and then smart utilization of genetic testing, specific diagnosis with multiple differentials, counseling, I think, is very important. If you are running a genetic clinic, then you have to have a counselor also, and it is a multidisciplinary approach. I think our patient just moves around in cornea, pediatric, and glaucoma clinics, and one should remember that genetic disorders are not always incurable. Thank you very much for your kind attention.
Thank you, Dr. Sunita, for that wonderful talk. If there are no questions, then we'll proceed to the next speaker. We have next Dr. Praveen Sen. She's a senior vitreoretinal surgeon at Dr. Agarwal Eye Hospital, Chandigarh, and former senior consultant at the Shankar Nethralaya, Chennai. She is voraciously, academic, and so many publications and presentations, and special interest in inherited retinal disorders. So, welcome, Dr. Praveen Sen. Thank you for joining us.
First of all, I thank Dr. Shailaja for having me here and having put up this session. इसको बंद कर दीजिए, ये नहीं चाहिए। नहीं। ये तो यही है, यही खोल दीजिए, कोई बात नहीं, इसी में खोलिए। So I think what we don't appreciate is the amount of hard work which goes to really, set up one case, especially where genetics is concerned. You have to have too many people involved, and I really congratulate Dr. Shailaja and for giving us so many cases which have been. What happened?
मैम आपका डिस्प्ले उधर जा रहा है उल्टा सूरज लोगो
So after the interior segment, I'll take you into the inherited retinal degenerations and how we go about diagnosing them, and I'll touch upon a little bit of treatment because I think Dr. Natarajan will take us more to the newer treatments which are available. नहीं हो रहा। So though all of us feel as if यहाँ पे लगाइए। Yes. Though all of us feel these is rare diseases that we are dealing with, but they are not so rare. Almost 20 to 25% of blindness in the working population is because of inherited retinal degeneration. And the new standard of care involves early diagnosis, characterization of disease, genetic testing, and familiarity and up-to-date knowledge of the ongoing clinical trials. Clinical characterization involves history, visual acuity, perimetry, multimodal imaging, and electrophysiology. And the vision will not only just be BCVA, but also refractive error, color vision, nystagmus, all these will be necessary. Fields, though we are not, as a retina specialist, we don't give too much importance, but here where inherited retinal dystrophies are concerned, they are very, very useful not only for diagnosis, but for knowing the progression of disease. And electrophysiology, which is forms the basis of diagnosis of IRDs, I'm just giving it in a single slide as an overview as to how this, along with multimodal imaging, can lead you to the diagnosis. And in this era of wide field fundus photography, this is the most vital investigation because it is helpful in documentation and looking at the follow-up of these cases. You can see here that if I just take the fundus photograph, we will probably miss a lot of pathology, which is very easily seen in cases of wide field photography. And fundus autofluorescence, you can see the top Mirante image. It does not show too much as to how much is the extent of disease, but is beautifully delineated on fundus autofluorescence. Some of the diseases will have a characteristic feature of ABCA4, which is peripapillary sparing of the RPE. So here, in most of the RP patients, you will have this ring which is present, and this ring is suggestive of the dying cells. It corresponds to the ellipsoid layer which is present here. And X-linked photoschisis, you can see that autofluorescence, if it is involving most of the area of schisis, it usually means it's an advanced nature of disease and it will not benefit by surgical intervention. OCT in IRDs can help you look at the prognosis as well as presence of macular edema, which is present or not. And lot of the diagnosis of macular dystrophies, including the Best disease, can be done based on OCT. Presence of associated higher reflective foci can be also a prognostic sign. And in gene therapy, what is also important is the EZ width, which is present or not. Good phenotyping can help you even understand what gene are you looking at, because if you have these typical features of an annular ring and schisis on OCT along with a typical ERG, you know it is the NR2E3 gene that you are looking at. And if you see cone dystrophy with these supernormal responses, you know that it is the KCNV2 gene which is known to cause cone dystrophy. Other tests which are also used include dark adaptometry, adaptive optics. And coming to genetics, how do you work on the genetics of these cases? First of all, you try to do a family pedigree and look at whether it's a recessive gene, dominant, X-linked recessive or X-linked dominant. Almost 300 genes are known to cause IRDs, and genetic testing is the new standard of care. As early as 2016, AO has given this task force that all cases with monogenic diseases such as RP and Stargardt's must undergo genetic testing, and genetic testing is particularly useful where the FDA approved gene therapy like Luxturna is already there, and if especially you suspect autosomal dominant or X-linked disease, which can be very severe, genetic testing is very vital. As was previously touched upon by the previous speaker, we saw that you could order a whole genome sequence, a panel gene, or a single gene. A single gene is more not very practical. So it's a gene panel which is ideally suited, because the whole gene exome can be very expensive and give you a lot of unnecessary information which you may not be able to clinically relate to. So gene panel reduces the cost and helps the results come within a month, and that can give you establish a good genotype correlation, understand the clinical diagnosis, appropriate follow-up, as well as give accurate prognosis to these cases. So both molecular diagnosis and good phenotyping is necessary in these kind of cases. This is a typical presentation of circle mutation, and this was another case that we recently saw, and a patient had macular atrophy, but when I saw the periphery, it had this kind of a well-demarcated area of coin-shaped lesions, and having known that circle could present like this, even in the absence of night blindness, we got genetic testing done, and it was definitely a circle which was a pathogenic gene mutation. But on the other extreme, this is a known case of RP. We know, everybody can see that this is retinitis pigmentosa, but genetic testing did not reveal any known gene. So it is not always, this is another example of AIOC204. This is a combination of good phenotype as well as genetic testing which can give you the result. So once you have decided that this is the genetic testing and you have done it, what next? Genetic testing comes with a lot of responsibility. You have to have a geneticist with you who can do adequate counseling, and the counseling is needed to be both pre-test as well as post-test counseling. Pre-test in which the family pedigree can be done, mode of inheritance can be explained, the nature and the limitation of these genetic testing should be discussed with the parents, because they would expect that once you have done the testing, now the child is going to be cured. It is not like that. So this is very, very important. And genetic counseling can be, both for the prognosis of the child as well as future offsprings. Just to touch upon the treatment, symptomatic in form of low vision aids, and these associated problems which can be seen in IRDs like choroidal neovascular membrane or macular edema will need to be treated symptomatically, either in form of anti-VEGF injections or in form of carbonic anhydrase inhibitors. So this is sometimes when you need a surgical intervention as well. And this is a patient of Jacobson syndrome, which is a chromosomal 11 deletion, and chromosome 11 also harbors the frizzled gene, which is responsible for FEVR. And this was the patient that I saw had operated because of FEVR, the patient had bled, so the blood had to be removed very carefully. And once it was done, there is visual rehabilitation, but because of the other associated anomalies of chromosome 11 deletion, the patient also had autism, dysmorphic faces, behavioral problems, and VSD of the heart. So multiple problems have to be dealt with some of these cases. Pharmacotherapy in form of antioxidants and vitamin A, and we know that finally it is apoptosis which leads to pre-programmed or early cell death. So a lot of anti-apoptotic agents have been used, including the basic fibroblast growth factor and other neutrophins, which can reduce the rate of cell death. So largely treatment of IRDs is in the basis of gene therapy, stem cell therapy, optogenetics, neuroprotective agents. So I think gene therapy will be covered by the following speakers, but it can be in form of augmentation or CRISPR technology in gene editing. And lastly, ocular prosthesis for end-stage disease. ARGUS-2 ocular prosthesis has been used, but with limited benefit because a lot of complications associated. Knowledge of the clinical trials, so just to enumerate that we have clinical trials going on for AIOC204, for choroideremia, for XLRS, for achromatopsia, for Merck-associated RP. So definitely these are the genes which should be, when suspected, patient should receive genetic testing and counseling. So to conclude, retina specialists need to remain uh, up to date to their knowledge of the current and genetic testing methods and and all the clinical trials which are happening. And targeted gene therapy has the potential, but it's not the only way to treat gene IRDs. And with that, I conclude my talk. I think this is just a beginning to a lot more work which is going to come very, very near future. I don't think it is very distant now. Thank you.
Thank you, Dr. Praveen. That was a very illuminating talk, and you touched upon very important aspects of genetic counseling. And I think our subsequent speakers will also cover it. Next, I would like to call upon Dr. Seema Das, who is the Director of Oculoplasty and Ocular Oncology Services at Dr. Shroff Charity High Hospital, and she would be speaking about implications of genetic diagnosis in retinoblastoma.
Thank you, Shalja. Thanks, Shalja, Professor Natarajan, GEGC, for organizing this session and for giving this opportunity to share our experience on working with retinoblastoma. So why we need to know the genetic status of retinoblastoma? Because we know germline versus non-germline RB has a different set of follow-up protocol, different clinical manifestations. We need to screen the siblings, screen the family depending on the germline status. There are systemic implications if the patient has a germline retinoblastoma. And it is also important while if the family is planning any future pregnancies. Little bit about liquid biopsy I'll try to touch upon, and the recent advances in trying to do a phenotype-genotype correlation in retinoblastoma, which until now is not very clear, trying to segregate the tumor into type 1 and type 2. So we all know about RB gene. This is probably the oldest known and the gene based on which all the human diseases has been worked upon. And we all know the heritable and the non-heritable forms, what are the frequency and what are the implications. And clinically it's an autosomal recessive disease, but it tends to get transmitted as an autosomal dominant. Another gene which has now been established with unilateral early onset RB is the MECAN amplification, though we don't see it very often, but mainly because probably we don't test the tumors very often. And we know the implication of prognosticating the effect of on the other sibling future pregnancies based on the laterality as well as the family history if the germline status of the patient is not known. So with this background, let's look at some cases. These are the typical way the RB presents, the unilateral, slightly older onset retinoblastoma, the first child, and a bilateral disease which tends to be early onset, tends to affect both eyes. And we generally tend to see more of unilateral disease, but I think it can vary unless and until with a large cohort of patients on a wider pool, the referral data can be a little biased. So looking at our own data, these are the 150 data of the initial 150 patients where we have done the germline testing, the consecutive 150 RB patients. About out of the unilateral patient, we have germline positive percentage of about 18%, which is slightly higher than what is reported in the literature. Usually it's 10 to 15% which is reported. Out of this whole cohort, 11 had family history of retinoblastoma, and these are the different type of mutation which has been detected in this cohort. So now, how does it make a difference in an unilateral patient? Like we see this child, very early onset retinoblastoma, unilateral, advanced tumor in one eye, group E at presentation with a neovascular glaucoma. It's an infant, as we can make out, but the other eye is absolutely okay. Now for this eye, we need to enucleate because there was no extraocular extension of the tumor, and we know that this eye is not salvageable. But unless and until we know the germline status of the patient, we can never be sure whether there is a possibility of the child getting tumor in the other eye or not. So we took up the patient under EUA, and we did a genetic testing for this child, and we found a germline mutation. And then we know that this child has a possibility of getting tumor in the other eye. Subsequently, on about 3 to 4 months follow-up, I think there was a small tumor which came up in the other eye. But since we weren't looking for this tumor, we could pick it up at a very early stage, just do a laser therapy, and it could manage the tumor at a very early onset. So unilateral RBU germline mutation, we need to look out for new tumor in the other eye. We need to keep the child frequent follow-up with EUA if the child is very small, and most of them will be small kid. And we need to follow the high-risk follow-up strategy. So there are different follow-up strategy which is given based on the risk, based on the genetic status of the child, whether it's a low-risk group or a high-risk group, and we tend to follow the high-risk follow-up strategy, means a more frequent follow-up for these children. What about bilateral retinoblastoma? So this is a slightly older child. In fact, this child was picked up on routine screening by one of our field workers, leukocoria in one eye, but when we checked the other eye also had a small tumor. So this is a bilateral retinoblastoma. Again, we know this is germline, but there was no family history. We did a genetic testing. He had a mutation in the RB1, and incidentally, he had a new sibling which was just born about 2 months or so, 6 weeks in fact. And this sibling was preterm. So this sibling was in fact taken up for screening for retinopathy of prematurity, ROP, but while the child was being screened for ROP, we could pick up a small tumor in the younger sibling also. Subsequently, this sibling also went on to develop another tumor in the other eye also, so that also became bilateral. But since all these tumors were very small, picked at an early stage, we could save the eye as well as the vision of the second child. For the first child, unfortunately, one eye could not be salvaged, but we could save the other eye. So these are the two siblings. This was before enucleation was done for the first child. So sibling screening is very important, not only for small children, but sometimes you get surprises. Like this family, these are the slightly older sibling. In fact, this kid, the first younger girl, was treated when she was slightly younger. This is his follow-up picture, current picture, but this child was about 2 or 3 years when we treated her. But this child has an elder sibling brother, about 7-year-old. And no symptom, nothing. There are no ocular symptom. Vision was okay. Everything was fine. But this child, the index case had a bilateral RB. One eye was bad, could not be salvaged. But as part of the routine sibling screening, we looked at the fundus of the elder brother also. Surprisingly, there was another tumor, partially regressed. It could be a retinoma, we don't know. But it looked some area to be active. We started doing laser for this child. And these are the picture after the laser where the calcification has happened. So germline status in a bilateral case, because we know if there is a germline retinoblastoma and if the parents are affected, if it's familial or if the parents are silent carriers, there is a 50% risk of one of the sibling getting affected also. And hence it is important to know also the germline as well as the clinical status of the parents to be able to give a good prognostication. And in our cohort, when you did a sibling screening, out of about 70 odd families, 5 had retinoblastoma in the sibling itself, and 3 of them had affected parents. So again, here we need to follow the high-risk protocol for screening. Trilateral retinoblastoma, we all know apparently intraocular tumor in this child, but when you did an MRI, there was a huge tumor sitting, and this is germline, we all know that. So RB's germline status has systemic implications also, because we know about second primary tumors which are at increased risk, especially if the child is given radiation, and soft tissue sarcomas are known to happen more often in the field of radiation if the child has a germline RB1 status. There are a few unique families. I think I'll skip it. Low penetrance retinoblastoma or the mutation. This part I can skip. And this is one interesting family where the father had bilateral RB treated. One of the child had RB. This was the first child, was why the family came to us. When we did the screening of the children, we picked up bilateral tumor in the younger sibling also. And the mother was pregnant. They were very keen to know whether there is a child of the, because these are all, both are girl child. They were very keen on getting a male child. So we counseled that it's a very high chance because the father is also affected, but still they wanted to go ahead with the pregnancy. We did a CVS. We found the same mutation which the father had and the other affected siblings had, but still they were not ready for the termination of the pregnancy. So eventually the child was delivered. Very small tumor. Immediately after 2 weeks after, I think, the delivery, we did the UA. We picked up the small tumors close to the disc, posterior pole. But since it was again detected early, we could treat it just with focal therapy. So preconception counseling and prenatal testing has a very important role as far as the germline status is concerned. This is the data of our patients. Interestingly, we did 6 out of the 20 families which were counseled. We did CVS for 7 of these families. 3 had advanced pregnancy, so it could not be done. 1 refused. And in 3 fetus which turned out to be positive, MTP was advised and they went ahead with the termination. And all these 3 families where the CVS had showed a mutation in the fetus also had heritable RB, means another affected family member, either the parent or somebody else in the family, also a tumor. So though the literature says it's 50%, I know it's a very small number to say, but at least in this series it looks like almost 100%. If there is a familial RB, the risk of getting another child affected in utero seems to be pretty high. I'll skip this video also. Okay, this was another family where 1 sibling was affected, but just to show that, this child unfortunately had to undergo a bilateral enucleation. We could not save either of the eye. But the younger sibling, we did a CVS. We found no mutation. There was no affected family member. And that child was actually born healthy and doing fine as of now. Little bit about liquid biopsy. What is liquid biopsy? Traditional biopsy, we take out tumor tissue and we check the genetic status in the tumor, but in RB we know that we can't do that because biopsy is contraindicated in retinoblastoma. So what we do, we try to identify the DNA from the tumor tissue in the fluid, that is the blood or any other fluid, maybe the aqueous humor. Most of the work on retinoblastoma liquid biopsy has been done on the aqueous humor, but in our setup we realized that aqueous is not relevant one because most of our patients do not have an anterior chamber when they present to us. Everything is destroyed. So maybe what is more relevant to us is blood-based liquid biopsy, or maybe in those patients who get a CNS mets, maybe a CSF-based liquid biopsy, and that's what we've been working on. And how it can help us, it can also help in identifying the germline status, because if you do not have the tumor, most often the unilateral RB, you tend to do the genetic status of the tumor after enucleation, find out the mutation, go back and check in the blood whether that mutation is there, or if the child is then germline. But since in RB we can't do that, we can do a liquid biopsy, try to identify the mutation in the blood, which is a surrogate marker for the tumor DNA, and then try to go back and see for that in the germline status. The same happened in this child, young child again, presented with an advanced unilateral retinoblastoma, other eye was okay. Germline testing, sequencing, first testing came out to be negative. But we are not very sure. It's a small child. We don't see non-germline RB in such a young age. So we went ahead with a liquid biopsy. There we could identify mutation from the tumor. So we went ahead and did a Sanger sequencing to identify the same mutation in the germline, and the same mutation was now present. Now, so you kept the patient on follow-up. Subsequently, again, the same child developed another tumor, small tumor in the other eye. So that's another utility. Other utility could be, again, this is one area which needs further exploration. In the CNS metastasis, because we know by the time we detect CNS metastasis by conventional cytology, it's too late. We can't treat those children. So if you could treat them or maybe detect them at a little earlier stage before the clinical manifestations have come, or when the bulk of the tumor in the CNS is higher, by doing a liquid biopsy from the CSF, like in this child where there was a recurrent tumor, and at initial presentation, the mutation which we found from the blood as well as from the tumor was matching, and when the child came back with a recurrence, orbital recurrence, still no CNS symptoms, we identify another set of mutation from the blood as well as from the CSF. Unfortunately, eventually down the line he developed symptoms, because right now we don't have any treatment based on liquid biopsy. Our oncologists were not very happy to treat just based on liquid biopsy till we have further data. But somehow this child succumbed to the disease. So maybe liquid biopsy, further work can be done. It can be a tool for early diagnosis and prognostication, especially for the CNS disease settings in our setup. And just a little bit about the two subtypes of the tumor which we are talking about, just to have a phenotype-genotype correlation. This is a very recent paper, 2022, in the Nature Communication. And it's a multicentric study where the group has done a very elegant study of about 100 plus patients, did a multi-omics-based analysis of the tumor as well as other mutational analyses. And what they found is RB actually behaves in two different ways. There are two distinct subtypes of tumor based on the genetic makeup of the tumor. And if we try to extrapolate those subtypes based on the feature they have given, the germline status, age at diagnosis, the laterality, though they have not mentioned about unilateral versus bilateral RB, but it actually hints towards that. So what they have found, the subtype 2, which is basically the unilateral non-germline late onset presentation in our setting, they tend to harbor a more wider alteration, more kind of genetic alteration, including MYC and amplification, as compared to the subtype 1, which seems to have a better prognosis. So maybe further study in this direction will help us find out why our tumors, especially the unilateral one, tend to behave a little more aggressively and tend to respond poorly to treatment. So I acknowledge the whole team here, oncology as well as the genetics and the basic science lab team here, who has been instrumental in sort of helping us with the RB genetics. Thank you so much.
Thank you, Dr. Seema, for that wonderful talk. I would like to invite Professor Natarajan now. Is there? So maybe we could go ahead with Dipanjana's talk first. We'll find him. So, so Dipanjana is a senior genetic counselor, and she would be talking to us about very important aspect, like you must be listening with from everybody, so many genetic diagnoses, but what's more to it, what more can we offer? And Dipanjana is taking care of the Organization of Rare Disease of India, the Kolkata and the East zone, if I'm not wrong, Dipanjana, right? So, yes, yeah. So over to you, Dipanjana.
At the outset, I would really like to thank Dr. Shailaja ma'am, the Ophthalmological Society of West Bengal, and also the AIOC for giving this opportunity over here. Very briefly, I'll be speaking more on genetics and genetic counseling and the utility of the testing. So if we are looking at it, then when we do genetic counseling, it's basically, it starts with, it can be just an awareness. You know, we want to, there's a certain condition in the family. We are trying to communicate that there can be a genetic background to this. There can be an inherited background to that. Discussing the options they might have, and then assisting the families to take decisions, as that can be retrospective decision or it can be prospective decisions. Now, when we are counseling, obviously we are taking care of psychological aspects, the consequences, the yield of the genetic testings, if we need to notify other relatives, or if there is a recurrence risk, if there is an age-related issue, or it's just a susceptibility or penetrance thing. So there are a lot of things that come in when we are counseling. The counseling is divided into pre-test and post-test. Pre-test would rather involve about the testing and why the necessity, and post-test would be our actionable points, and if there are more referrals that may be needed, and further consequences. So basically, counseling would be divided into assessment phase, diagnostic phase, analysis phase, communication phase, and then referral and support. So as you can see, if I just give you this, that you know, we are seeing 2 children with truncal obesity, post-axial polydactyly, we see hypogonadism, we see acanthosis, and we see that they have RP. So can I ask, like, what are we looking at? We are probably looking at Bardet-Biedl syndrome, right? But now, just that see here, eye is one part of the entire syndrome. So this child, if we know, if you're just looking at RP, then it needs to be managed for other conditions. We don't even know whether this child would need. And if the sister, the elder brother would have known, then probably the younger sister would have been diagnosed at birth. So very simple things. So there are many genes. Now itself, Bardet-Biedl syndrome can have so many different genes, there are different types. So there are many genes and many diseases. So, and not everything would be genetic. So to assess this, that whether there is a genetic etiology or not, and whether there is a necessity to do the testing and there is an actionability or not, initially the counseling would deal with the yield of the test. And then what panels are we going to test? Because if we look at it, like increasingly as we grow, like in the previous slide as you are seeing, that number of genes identified from like 80s to now has increased significantly, and we are getting new phenotypes, new genes, and hence the need for testing becomes very important. And there are very overlapping genes. Like if you see over here, you can see night blindness, retinitis pigmentosa, just cone rod dystrophies, the LCS, so everything is overlap. So it might present as something, and somebody said in one seminar that, you know, genetics has made us be more humble, because what we are thinking might not be that case. It might be something else that is coming up, and that is very important for the testing. Now here there's a 7-year-old child, and this child is with sensory neuronal hearing loss and optic atrophy. Now if we just look at these three, see it's a consanguineous family. If we just look at these three, what are we thinking of? Alport syndrome. So that is exactly what we thought. But here see, there's a small catch. We got a gene homozygous for Alport syndrome, but see, we got another gene which is for optic atrophy. Alport does not cause optic atrophy. Alport will cause some other eye manifestations, right? So here, if we would have just said that the optic atrophy is due to Alport and just test Alport specific genes, we would have missed the second gene, and probably the care to the child would not have been complete. So this is why, this is how here, in this case, the family has helped. Now this was a consanguineous family. So here comes the role of inheritance. So if we know what kind of inheritance is there, we can also help the family plan their future directives. Now this is another case where we show that this is a known case of Usher syndrome. They want to have a family. Now just doing a testing, so here retinitis pigmentosa and hearing and imbalance, so we are saying it's Usher syndrome. My genetic testing yields a variant which is related to Usher syndrome, but is this it? Unfortunately, if we just leave it here, we will not be able to answer the question that we are asking. Because you can see here 2 mutations are there, but I still don't know the inheritance. This is autosomal recessive, so 2 mutations has to be in trans, which means it has to come from either of the parents, while if it comes from just one parent, it will not cause a disease. So if we know it is the other side, it's in cis, then we are actually missing another variant, and we need to look at further genetic testing. So hence here, if we don't counsel the parents, it will be a problem. Now in this case, say here there is another gene which is related to retinitis pigmentosa, and hence carrier screening also becomes important in the woman. We can offer tests like amniocentesis, PGT, and we can also offer donors and test the donors and go ahead with that. Also, we have a panel of testing. So we have karyotype, we have MLPA, we have the panel of genes. Depending on what we look, we will offer those kind of testings to the patient. Now here there's another study where this is an established family which has retinitis pigmentosa. In this case, the brother is known, the other sister is known. We wanted to find out whether this sister had it or not. Understand, here I highlighted the word deletion. If I just do a genome sequencing in this case, I would miss if I don't do an MLPA. So choice of test over here becomes very important. Now, as you can see, these genes have a spectrum, and this spectrum is extremely important for us to understand what test we should offer, what is the yield of the test, and what test we should offer, and whether we are missing something. Coming back to the first case I showed, this is a Bardet-Biedl syndrome. If I do just exome and leave it over there, I would be missing this contiguous deletion. So as a geneticist, it's my duty to understand and take and counsel the patient for cascade testing. So hence one test might not fit all, and hence the counseling is necessary. Also, if I'm getting a homozygous contiguous deletion, I need to know the exact position so that I can give them a prenatal counseling which is necessary. Yeah, just take 2 more minutes. So this is a family where you see this person has an anterior segment disorder, and he has 2 mutations in PXDN gene, and we tested the parents. They are also in the PXDN, but this is a variant of uncertain significance. Now if you're looking at a variant of uncertain significance, ACMG has given us 28 standard criterias. Now if we are looking at something and here my segregation has matched, then I can go back to reclassify these variants depending on these 28 criteria. Because of shortage of time, I'm sorry, I'm just running. We could reclassify the other variant, but we couldn't reclassify the one. But then again, one likely pathogenic and one VOUS entails us for a prenatal testing, and we can help the family if needed. Now, so what we need to do is assessments in the sense of deep phenotyping, family history, genetic history, clinical interpretation, and then comes the clinical use of it. So we are doing it for diagnosis, inheritance, predictions, and also for the care that we are giving, and right now the potential therapeutic options. So it's a multidisciplinary team which will have clinicians, the labs, the patient advocacy groups, and also other referring clinicians which might be needed for us to say. So it can be prospective or retrospective. And there are a number of clinical trials that have come up. It has opened. There are more than 30 ocular disease trials which are going up. And in this case, the psychological aspect of counseling becomes extremely important. So while we counsel, we involve the patient in the decision. It might not be an optimum testing for them, but it should be a testing which the family is comfortable with. The idea is to reduce the patients which are historical, detect them early, and treat them. Thank you.
Thank you so much, Dipanjana. So thank you so much. It was really very much practical, and I'm sure everybody is learning from your talk. And we'll move on to the last talk of the session, which is by Professor Natarajan. He needs no introduction. He's Padma Shri awardee and very great, good vitreoretinal surgeon. And he would be talking to us about what's new in the world of therapeutics in genetic disorders.
Thank you, Shailaja. And Shailaja is our Secretary General of Global Eye Genetic Consortium. So I'm happy to hand over and give her all the tasks for genetics in India. And we are struggling for last 10 years now. Can you have the slide on? So actually it's a very important topic, and fortunately we also have a tomorrow one session with Jerry Shield. Yeah, Jerry Shields in, I forgot the time, but tomorrow afternoon it's there. What happened? No, second. So, thank you. Can I have the slides here?
Put on the slide.
No, it's not coming. So I'm
Little help
happy
here,
to say
please.
myself and Dr. Parveen are together in a group of hospitals. She's in Chandigarh and myself in Mumbai. And my dream is to create a network to work on genetic eye diseases, because my father started the first genetic eye clinic in India in Government Ophthalmic Hospital in Madras in 1984 with the Professor Kumar Manikvel and one Dr. Ratna Savabadi, who was a veterinary physician with genetics background. So we know that there are about 10 million blind people worldwide, and my thing is working on artificial retina, implantable electronic device designed to stimulate sensitization of vision in the eyes. And so these are the ideal candidate. They are working on retinitis pigmentosa, and the other diseases they have given ARMD, Stargardt's, macular dystrophy, choroideremia, and also Leber's congenital amaurosis. But there are contraindications for any surgery, and the evolution is from 1996 the work is going on. I'm glad I'm working with Mark Humayun from 2004. He started working in publishing in 98. He actually did his PhD in MIT Boston on retinal prosthesis, apart from his MD from Johns Hopkins, and also he worked with Macamar. So Stanford is doing research, and then we have several implants, and this is happening for the last 25 years in the world, and also transcranial magnetic stimulation. So how it works, you have a retinal implant implanted in the either in the epiretinal or subretinal space. You have dark glasses with a camera, and then earlier we had a communication from the camera to the chip by a real electrical wire connecting. And I see Dr. Santosh coming behind. He is working on retinal stem cell with Dr. Srinivasa Sada in the stem cell, right? Santosh, you are working on stem cell, right? And there are a lot of publications going on. I'm happy that primary work has been done in India, and Dr. Santosh was a fellow of Aditya Jyot. So there are several things have been happened, and recently I came with Dr. Mark Humayun, and I'm in touch with this company for where they have a video capture and transfer unit.
IMIE 智能视觉植入器，世界首创256通道柔性电极视网膜上植入式电刺激器，由眼镜、视频处理装置和植入体3大核心部件构成。使用者佩戴装有摄像头的特制眼镜，捕获视频图像，并传送给视频处理装置。视频处理装置将视频图像转化为电刺激数据，并将处理后的数据信息通过视频连接线传输给眼镜上的外部线圈。通过眼镜上的外部线圈，将能量和数据无线传输给植入使用者眼内的植入体。植入体的专用集成电路根据接收到的数据生成电刺激脉冲，通过柔性电缆传输至贴附在视网膜上的电极阵列，电刺激脉冲诱导视网膜视觉神经细胞产生电生理反应，通过视神经传输至大脑视觉皮层，使使用者产生视觉感知。
今天是第37个国际盲人节，我国现有视障人士是1700多万人，而随着医学技术的不断发展，也为一些盲人患者带来了福音。
在盲人节的当天，湖南长沙盲人刘曙芳就收到了一份特殊的礼物，通过在眼球上安装256通道柔性电极视网膜上植入式电刺激器，以及一副装有摄像头的墨镜，完全失明3年的刘曙芳又重见光明。
KEM Hospital Bombay, which I'm planning. So you can see that this is actually if you see the letter is so small and it looks great to see, but How practical is we don't know. But unless we do something and follow all the ethical rules, yeah. But we started late, man. No, you gave the hall late. But 5 minutes bhi hai. Okay, so Santosh, you are the next session. I would request you here.
10月
He is
15
my
号
fellow.
在
Anyway, I'll conclude. So main thing is there are so many places you can implant. So this is what was told in 2002. The first patient to receive a prototype implant in 2002 described what it was like being able to see large letters and to differentiate between a cup, a plate and a knife after being blind for over 50 years. And this is what I do as a vitreoretinal surgeon from 1984, thanks to Dr. Badrinath. But now the half of the book, Parsons, that time when I was doing my PG in 80s, my father said half the book you can't do anything. That is inherited retinal degeneration, whatever Dr. Shailaja presented. And there are so many things. There is a photo diode array. We are Indian Institute of Technology is boasting of technology, and I worked with them 5 years. I would say it's my I invested time, but I had no result, and that's the problem. And these are the subretinal and epiretinal. There are so many groups working in the world, and this is about 12, and most of them I am in touch. And finally, Argos 2 was approved by FDA. And then I think 100 patients have been done world over except India. And India could not get the, even though I got the approval from this site. And this is Argo 2 used in patients of RP and other outer retinal degeneration with bare or no light perception. That means the photoreceptor layer should be damaged, and beyond that, in the ganglion cell layer and optic nerve should function. Then only the artificial retina will work. And then this is other implant, and then this is a Harvard device. All are similar, but they are successful in Boston retinal implant. And this is Australia is doing it in the suprachoroidal space. And then there are, so Dr. Gisbert Richard, I worked with him. He retired now, but he's continuing research from Hamburg, who was the president of Uretna. Mark Humain, we are continuously working, and I love his perseverance. He got the Innovation Award for the artificial retina by Barack Obama. But whatever it is, the patient can't see, and that's where as a patient you have problem. And Dr. Sachs Helmet also did. He came to Bombay. We did an MOU with Aditya Jyot, but again the company went background. So to conclude, it has been 40 years since Arne Larsen received first fully implanted cardiac pacemaker at the Karolinska Institute in Stockholm. And now this company, Intelli Micro, is hopeful that they will get a Nobel Prize for the group. And I don't know whether it will happen. And there's a gene therapy, so I just use this, the last video, and then close it. The video is not working. Okay, so in the gene therapy, the main thing is a lot of research is going on, and I'm actually, these are the diseases studies are going on, and then so many genes have been identified. That's the reason we have to be ready in India with genotype and phenotype, which we are not ready, and so that we know who will. So this is the FDA approved the novel gene therapy to treat patients with a rare form using Luxturna. And again, you need a vitreoretinal surgeon to inject the subretinal space, and even this optogenetics, which has been done. So there are a lot of trials going on, but this is what I like to conclude my talk by telling what Dr. Charles Skippens told me, and he's put it in his research, in the Skippens Research Institute, that we never say never again to a patient. And I think this is what Dr. Santosh worked in Orissa, and being work done in NEI. I'm going, Dr. Kapil Bharti is doing induced pluripotent stem cell. I don't know whether you know, 10 years back, they got the Nobel Prize, Yamanaka, at the age of 49 for using the iPS cell therapy. And his Tetsura did the first trial, but unfortunately it's teratogenic. Thank you very much. So we can have a quick group photo, and Santosh, you can take over.